Good day. This is Charles Denham, and I'll be your MC today for our 127th webinar, 127 months in a row. I can't believe it. It's been such a terrific run, and we have a great topic today. However, I have a couple of housekeeping duties, and I'm on slide 3, and I just want to make sure that everyone's WebEx volume is to the max, that your computer volume is maximized, and that your external speaker volume is maximized. In the event that it is not on slide 4, for those that have the slides, you can click on the Participants tab and then click on the phone icon, and you can request a phone line for those that are live today. For those that are in future on watching on demand and recording, this option won't be available to you. So slide number 5 addresses where to get the slides and to go for further materials. If Dr. Huddleston, who's our great speaker today, has further resources or links that she wishes to make available to you, and we have additional assets, we will post them there. For those that do not have the slides yet, go to www.safetyleaders.org and click on the upcoming events and click on today's webinar, and you'll be able to download those slides. It'll take you to a page which we have on slide 6 with Dr. Huddleston's picture, and additional resources will be posted there, and that's where you'll be able to have the opportunity to watch the video of the program in the future and download the slides. On slide 7 are our social media addresses, and we are going to purpose to put a lot more on social media here over the summer and by September. On slide 8, our purpose statement is we will measure our success by how we protect and enrich the lives of families, patients, and caregivers. Our mission is to accelerate performance solutions that save lives, save money, and create value in the communities we serve. And today's topic, I think, really will address that. Our disclosure statement is on slide 9, and there are no financial disclosures, no product, service, or technologies that are being addressed today or covered. The speakers and reactors today, we have Jeanne Huddleston, who will be speaking, who I'll introduce and address in terms of her bio, and Arlene Salamandra, a long-standing patient advocate and patient safety champion, who will be our voice of the patient. And we actually have reactors who will be reacting online today with our Q&A section, which we encourage you to participate with. On slide 11, we have the picture of Arlene Salamandra. Arlene, please open us with the voice of the patient. Arlene is the former board member and staff member and staff coordinator for Families Advocating Injury Reduction, FAIR. She's been a patient advocate for years. She's a co-author of a number of papers in the medical journals and has also served on federal programs and on the National Quality Forum Safe Practices that committees support, helping write the sections for patient advocacy in those sections. So Arlene is also a terrific champion for workplace violence and prevention of bullying. So she will really be a great asset in the months to come when we cover that topic. Arlene, would you open us with the voice of the patient?
Thank you, Dr. Denham. I would like to thank everyone for being on the webinar today, and thank you, Dr. Denham, for having, excuse me, the patient's voice here on the webinar, because it's so important to include the patient and their perspective for any type of improvement to our health care. So thank you, and I'm looking forward to today's presentation. Thank you.
And thank you, Arlene, for your steadfast support. Also, Arlene was part of the team that worked on the hospital-acquired conditions evidence program that we launched as a network that helped push the hacks over the goal line, as Dr. Valak told us in December of this year. So we're putting our roller skates on. I'm going to go through a number of in the news slides in order to get to Dr. Huddleston as quickly as we can, because the topic she's addressing is really one that so many of us want to hear about. First off, just a couple of days ago, one thing to keep in mind is robocalls to hospitals are creating a new type of crisis. Tufts Medical Center had enormous overload of calls. So read the article and take a look at this. This is a new threat that's just come on the horizon of robocalls hitting all of the hospital phone lines. In addition, more and more lawsuits regarding infections, a June 17th article in U.S. News. So, and the one thing I'm going to do is really move through a number of slides very quickly in the news, and there are additional slides that are in the resources section at the end of your deck that you can pull from, and a number will back up some of these topics. So keep your eye on these infections and the lawsuits. There was a great review article by the Association of American Medical Colleges. Take a look at it. 20 years of patient safety. We took the liberty of kind of dropping it into a timeline here, starting with the To Err is Human report in 1999 and bringing us up to today. Is it a complete review? Absolutely not. Does it cover everything that we know that is important in it, for instance, the hacks that we discussed a couple minutes ago? No, but this is a nice longitudinal review of a number of the topics of the 20 years in safety. One of the topics that we've been covering for you it has been this, the letter that has gone out from the NIH to our major medical centers regarding corruption and influence over a number of our research programs. And this letter went out, for those of you that haven't been watching our series on this, we're addressing a lot of these issues. So in the last month, more news articles are hitting regarding Chinese professors and those, and it's not only China, but China has popped up more frequently than others. So over the last month, we've seen more detail regarding nation-state espionage and those that are trying to kind of corrupt our medical centers and our medical research. This is really key because it's going to stop NIH funding and really waylay a lot of organizations. Also, MD Anderson is a close partner of ours in a lot of the work we do, and it would be improper for us to not bring up anything that pops up in the news. MD Anderson is also being challenged regarding CMS, regarding safety violations, as have a lot of our number of our medical centers. So this, for you, those of you that are patient safety and quality officers, a lot of this is hitting the news. It's critical that we all keep aware of the issues that are popping up. And an enormous problem with academic fraud. So another article popped up since our last webinar, an MIT professor also addressing some of the research issues. Retractions are an enormous, they're in the thousands a year now. And the other, because we're focused on this fraud issue now, fraud in residency applications, this has even been uncovered in our recent matching programs. So keep your eye on these areas of importance. If you look more broadly across our industries, the top reasons for CEO departures from our Fortune 100 and our Fortune 1000 companies that are outside of healthcare, 39% of the 89 CEOs who departed in 2018 left for reasons of unethical behavior. And I think an enormous focus of our investigational reporters on medical fraud, on patient safety issues, but also ethical issues, which we think is terrific. This one story that we've been following over our series of webinars is the Johns Hopkins story that has an aggressive set of investigative reporters have undertaken. There are now more than 30 articles regarding the Johns Hopkins, actually the entire system. It started with the Children's Hospital in Tampa Bay, and Tampa Bay Times has followed this. But there are a number of cases we're following to put together an educational series, including Hopkins, Memorial Sloan Kettering, Baylor, St. Luke's, the Brigham and Women's, Vanderbilt University, Duke University, and the University of Maryland. The most recent article on Hopkins has recently come out showing the financial impact. And what we're really learning is that not only are the culprits who may be involved with patient safety an issue, or the senior leaders, but also the enablers who have allowed patient harm to occur and have not felt empowered to be able to say what's going on. So we won't go over this in detail, but if you go to the resources section of your slide deck, you'll see an updated list of all of the articles addressing this, and they're very, very instructive to all of us. Finally, and we're at 9 minutes after the hour, my hope is in the next three or four minutes to just finish what's in the news, continuing to update the Healthcare Innocence Project, which is focused on the new DNA of today is digital DNA to help protect caregivers who are improperly accused of things, or when something goes wrong in a patient safety environment and we kind of leave the patient caregiver out to dry, and also making patients and their families to blame. So we're continuing to watch that. Shifting gears to the other series that we're following for you, or we've been developing for you, is the focus of the MED program on 8 leading causes of death to children, youth, and folks in their workforce years. What's popped up in the last month is it turns out that women are 27% less likely to receive CPR than men, because people feel uncomfortable doing CPR on women and touching them improperly. And so now they're even developing products to put over our mannequins. And we're doing a tremendous amount of CPR training in multiple high-performance research areas. And we've realized this is a really big deal. When we train SWAT team officers and policemen with the MedTech program, we say we've got to leave the PC at the door. When we're taking care of somebody, we need to be able to look at exit wounds, entrance wounds, pat downs for blood loss and for severe trauma. We've added to the YouTube series of patient safety briefings. You'll notice in the right lower quadrant of this slide, the rapid response team video will be posted by the end of tomorrow, and this is a complement to the Campus Safety Magazine articles, which we've been asked to produce. The first was in December, addressing 8 leading causes of death using the Stop the Bleed program and CPR training, in addition to other preventative techniques. The second article they asked us to do was effectively responding to active shooters in healthcare facilities, because Campus Safety Magazine addresses universities, hospitals, and faith-based organizations. The third article they asked us to do, which was released last week, is on applying the rapid response team approach that IHI pioneered in the 100,000 Lives campaign, and bringing that to universities, schools, and churches. And we just finished that article. It's been published as of last week, and a video that complements it, and the link will be on the webpage for you on that, will address it. So now, in the next 3 minutes, I'll just address our survey from last month's webinar. We had a huge response, a very positive response to workplace violence, suicide in hospitals, but also drug diversion. So some of the articles that have popped up, and this is a pretty hot topic of escalating workplace violence. We want to remind you that we're going to have a hospital and healthcare workplace violence webinar in August of this month. But the suicide rates are up 33% since 1999. Again, go to the original articles. I'm just going to kind of walk you through them. One of the focus areas we've been working on all last year was the opioid crisis. Now it turns out that parental medical claims for opioid prescriptions appear to be correlated with an increased risk of suicide attempts by their children. But these two articles have just covered this. Again, I'm not going to read the pages for you. This is for you in case you are making arguments for an opioid program. Suicide rate for girls has been rising faster than for boys. This NPR article just came out since our last webinar. And we covered suicide in the hospitals, but with the overlap with drug diversion, we're seeing an increase in physician and caregiver suicide risks. So very important to address that. Also, just from last month, we addressed the leapfrog findings for hospitals. As we start to address the survey questions from last week. We covered drug diversion and suicide. One of the things to really keep your eye on is the rise of cocaine-involved deaths and stimulants, and mixing psychostimulants with fentanyl. This is, I think, probably going to be the fourth wave of the opioid crisis. So what we did was we addressed for, I think, the third or fourth time, drug diversion. We have Kimberly New addressed that in our last webinar, and so we'll just show you those results. I'm at 14 minutes after the hour. I'll be done in the next 2 minutes, and then we'll move to Dr. Huddleston. But we covered drug diversion and patient suicide prevention last month. It looks like you as an audience still want more on drug diversion, a critical problem. 52% of you gave it a 10. You can see 90% agreed with wanting to have more. I'll allow you to review on slide 48 the free text entry topics of what you would like in the next webinar. On drug diversion, we ask about emergency department safety, and again, we got a pretty strong response, 36% 10s, 22% strongly agree. So we will be addressing them. Free text entry is on slide 50. And errors of omission, and this is a lead into you, Dr. Huddleston. We asked our audience last month, would you please tell us whether you want more? We already had you scheduled, but we just wanted to see how strong the response was, and we've got over 550 organizations on today. 49% of you gave it a 10, 14% a 9, so very strong. And we sent this slide to Dr. Huddleston regarding the specific topics. I think she always covers almost all of these in her presentations, but you can go back and look at those topics. So with that overview, I think I'm only a minute over time. It's such a great pleasure to introduce Dr. Jeanne Huddleston. For those of you that haven't heard her speak, she's absolutely spectacular. I always, when people say, well, tell me about Jeanne Huddleston, I tell them I think she's our next Dawn Berwick. She's having an enormous impact, having pioneered the way for mortality reviews at the Mayo Clinic. I'll never forget when she told me about presenting to the board at the Mayo Clinic the mortality reviews and them saying that they wanted to see more data. She went back and got a master's degree in industrial engineering and measurement and has just really been pioneering the way of a data-driven approach to improving care and then leading the way in at the Mayo Clinic. She started a global collaborative, and Jeanne, when you close, please let everyone know how they can join your collaborative. We think it's absolutely terrific. Everyone is learning from this community of practice. She has finished her residency at the Mayo Clinic in medicine. She was the past president of the Society of Hospital Medicine as a hospitalist, is multiple research papers, and she'll probably share a little bit about the work that she's doing. She received master's degrees in both clinical research and industrial engineering. So, Jeanne, thank you. God bless you for the great work you're doing. We can't wait to hear what you have to share with us as an update on mortality reviews.
Wonderful, and thank you so much for the opportunity to be with you and all of the folks that are on the webinar right now. I sincerely appreciate the opportunity to share what's been going on over the last 18 months or so since I last had a chance to fill everybody in on this work. And there has definitely been an evolution in what we're seeing and the work that we've been able to do at many of these sites. I'm going to go through with you mortality reviews and patient safety, a 2019 update, and it's basically going to be an evolution of what's going on after we do mortality review and some of the potential of expanding that learning and evolving as learning organizations. I am fundamentally biased by this work. I am energized. I have not had a chance to tell Chuck yet, but I have retired from Mayo Clinic. I'm still practicing physician here, but I'm doing part-time work so that I can dedicate the rest of the next 20 years I've got left in me to spreading this work that was started at Mayo and is making a difference across the country and now in 3 other countries in the world. When we started, so I'm going to give you some a backdrop in terms of how we got started and then how it's evolved and the things that we're learning. So just to back up to 2003, which I know feels like a really long time. When I look in the mirror, I am pretty darn sure that 16 years have not gone by, but it's been amazing to see how much we've all grown and how patient safety across our country has grown over those last 16 years. But when we started, we recognized that the patient safety iceberg was very common patient safety sort of icon. And we recognized, those of us who were in the trenches, working in the middle of the night, et cetera, that the things that our leadership knew about were at the tip of the iceberg. And the stuff that we had to get through in the middle of the night to ensure that our patients had timely diagnoses and treatment was the stuff that was lurking below the surface. It's the stuff that our leaders didn't know about. They weren't the dramatic things. They were the nuisance things that maybe delayed getting the patient to the ICU or delayed getting a lab test done or couldn't get the right consultative team or expertise to the bedside. And we knew that we needed to address some of those things, but after decades of complaining about them, we were all surprised when nobody was willing to fix them. And so we took it upon ourselves to say, all right, our leaders aren't going to fix things if they think we're whining. So we need to come up with a way to name, identify, quantify, and qualify what's going on below the surface of the water in a productive way so our leaders can hear us. So we set out to learn about what was underneath the surface of the water, because the patient safety reports, sentinel events, incident reviews, all those things were happening in a very visible space. But what about what we were actually experiencing and providers? What was keeping us from doing our best job every day? This is a publication I've shown many of you before. It was published in 2014 in the Journal of Patient Safety. It covers the first 7,500 consecutive deaths that we reviewed in Rochester, Minnesota, how we made the decisions that we made, how we included which patients, who did the reviews, etc. So for your reference, it is in that article. In 2004, so it was 2003, there were 3 hospitalists and 1 nurse, and we wanted to figure out what was going on below the surface of the water. So this was the charge we wrote for ourselves, to create a meaningful mechanism to review deaths. Now, the word meaningful isn't often in charters or charges for new committees, but it was very intentionally put in this because we, as people who were volunteering our time to do the reviews, we wanted to do meaningful work. We wanted the hours we were spending in the nights and evenings and weekends to make a difference for ourselves, our fellow providers, and for the patients. So it wasn't going to be another counting exercise where we would count the reports that people sent in and make really pretty charts and show them to our leadership, get patted on the back and sent back out, and nothing would change. We were tired of that cycle of not making forward ground. And so we put the word meaningful in there intentionally. Now, it took us 5 to 7 years to figure out how to learn in a multidisciplinary, multi-specialty way using a modified Delphi approach. It took us a while to figure it out. And I'm going to share some of those mechanisms with you, but most of it is in that article that I referenced. And then 10 years later, after writing that charge about doing meaningful work, our Chief Quality Officer, Dr. Paula Santrak, who is recently, after more than 10 years, out of that position, she asked me, when can we start learning from the living? Don't you think there's people who are surviving in spite of us? It was a recognition that the methodology that took us a while to develop in a multidisciplinary, multi-specialty way was valid for all types of learning about different patients, not just mortalities. It was like all the lights in a room all of a sudden went on, because what we recognized was it wasn't about deaths. When we started out to learn about what was going on under the surface of the water, we picked mortalities because they were a convenient cohort. I mean, 2003, we were still in paper. And we knew that if we pulled those charts, no one was going to take the charts off our desk. They weren't going to disappear, so we could get them reviewed at any point that was convenient. For those of you who used to work in paper, you know what I'm talking about with those disappearing charts. So we picked it because it was a convenient cohort, just like researchers have a convenient sample that they work from to get their research started. We did not set out to do mortality review. Unfortunately, it got legs, and now everybody wants to do mortality review. We set out to learn as an organization so that we in the trenches could inspire and influence our leaders to make the changes that needed to be made. We didn't start out to do mortality reviews. So as a part of what's moved out of Mayo in the Safety Learning System Collaborative, it's just plain a meaningful mechanism to learn about opportunities for improvement. Not about specifically adverse events, not about acts of commission, but opportunities for improvement, the way we would want our loved ones to get care. And we still define it as we want it to be meaningful, because if it's not meaningful, we shouldn't be wasting our time doing it. We want it to be understandable, measurable, and improvable. Over the course of the last 3 years, we've recognized that the disciplines that we've integrated into this work are widespread and aren't always seen in the same venue, but are all completely intentionally wrapped into the work that we're doing, both from an organizational change perspective, organizational learning, high reliability, human factors, and implementation science in terms of putting together the projects that we need to fix things in a very defined way that they can be measured and the data can be shared to leadership so they can understand how their investment in that particular project is paying off. So all of this is brought together, and the resilience piece is one that we've just added recently. Resilience engineering is a new field in the engineering space that we're studying, and it gets to all of the things that we're facing in healthcare around the burnout and the suicide. We believe that no one should ever suffer or die as a result of process or system failures in healthcare. And we believe that that should not just be the case for our patients and family members. That's obvious. But it should also be the case for all of the nurses and doctors who are practicing in our system. Our bright yellow warning light, caution light for how we are driving practice forward on the backs of our providers is this concept of burnout and the suicide that was brought up by Dr. Denham. You can teach me deep breathing exercises all day long, and you can tell me what I need to do resilience, and I can do yoga and all of these things where I own my own burnout. But if you as healthcare leaders don't fix the broken process and systems that keep me from getting to the patient to the ICU when I need them to be there, that don't get the medicine to my patient when they need it, or don't provide the resources that are necessary in an ICU so we've got ICU patients out on the floor, whatever it happens to be, if those things aren't fixed, I'm not leaving the bedside. I'm still going home late. I'm still missing dinner with my family. I'm still angry when I go to sleep, tired when I wake up, and desperately wish that things were going to be better. Some of the attrition that we're seeing in healthcare isn't just people leaving or suicide. We have people all over who are reducing their FTE and going part-time. They're reducing their FTE and picking up teaching opportunities or research opportunities or community opportunities to try to get out of the grind of the practice. We have to fix the things that get in our way. No one comes to work to miss a diagnosis of sepsis or to watch a patient die in pain. That's not why we went into this field. But we also didn't go into this field to fight the system to get the right thing done. And so the work that we're doing in all of these hospitals is an attempt to fix those processes and systems that fail not only our patients and family members, but on every side, on the other side of every coin of a patient and family member suffering is a set of providers who are suffering as well. And we've got to recognize that and fix those things. And that's what this work is about. We currently have to 106 hospitals and counting. We now have more than almost 4,500 patient stories that have been told over the course of the last 2.5 years. And each of those hospitals in these states, Indiana should be colored in yellow as well. We've now also added Saudi Arabia, a couple of hospitals there, and are growing in many other states over the course of the next 6 months. These hospitals that are participating can look in the eyes of any family member that walks in and asks about their loved one, and they can tell the story of their loved one's experience before they died or before they had a readmission or before they had a delayed diagnosis, and they can look at them and say, we honored your loved one's life. We found that 3 or 4 other patients had the same experience as your loved one, and here is a quality improvement project that we're starting or that we've done that's going to fix that. all our patients and family members want to know is that we've learned from their experience and are going to make it better and hopefully not allow it to happen again. We're doing this in hospital sizes of 51 beds to 2,200 beds. This methodology can be adapted to work anywhere. And the adaptability of it is really an important portion, because you can't take something that was born out of a cornfield in Rochester, Minnesota, and plop it in British Columbia, Tasmania, Saudi Arabia, Boston, San Diego, and Florida, and the VA system and do thou shall do it this way. We can't. You have to standardize the 80% and allow for 20% flexibility so that it can fit in whatever culture or whatever patient group or whatever types of providers or resources a particular hospital has. People often ask, how is this different from classic M&M or root cause analyses or peer review? And we've learned to sort of describe it in this way. So in a compare and contrast, when you're doing a peer review, a classic M&M or root cause analysis, you have a patient that has been identified, or maybe two patients that have identified, often reported out voluntarily or confidentially, and then they get reviewed either by a group of peers in a public forum like with an M&M conference, or in a private forum like with a peer review, or with a group of multidisciplinary folks in a root cause analysis. And that individuals who participate in the care may or may not have an opportunity to participate in that. And then a determination is made about what needs to be done about that particular kind of case. Now that works, and that must continue to exist. We all need to have the ability to learn about our own practices and to get better as individuals. But the safety learning system has been developed around cohorts of patients. So basically, instead of individual patients being studied, we are taking a population health or a public health approach by taking 100 consecutive patients, not screening anyone out, learning about consecutive patients, trying to remove as much bias as possible, and looking at particular cohorts. So we have groups of people that are doing mortality reviews. We have others that are doing readmissions. We have some that are doing opioid related issues, readmission in the VAs for COPD, pneumonia, etc. So people are looking at a cohort that they want to improve the care on, or the ones that they haven't been able to do a thorough system diagnostic to understand what's going on for those patients and what exactly needs to be fixed. And so we look at groups of patients, and through those groups, that cohort, we use our multidisciplinary, multi-specialty, modified Delphi approach, where we identify issues and come to consensus around opportunities for improvement. And in those consecutive cases, we always find clusters of patients who had similar experiences. And in those similar experiences, we have patients who are pointing to gaps in our very well shored up process and systems. We're all practicing in great places. We all have amazing standard operating policies and procedures, and we all have providers who are giving their hearts and souls to these patients. Yet we're finding clusters of patients who slip through the cracks, who find a vulnerability in our system that patients are slipping through. And we study those patients with those common experiences and identify the common threads that we need to fix and shore up that vulnerability that the patients pointed out for us, so that no other patients ever fall through that crack again. And then we share that learning as broadly as possible. Again, another difference between the other single patient methods of learning. So that's our compare and contrast to these other methods. And to us, they're better together. And I'll show you what I mean by that in just a moment. As we do this work, I call us splitters, not lumpers. We are trying to identify every hole in the Swiss cheese, because from a random chaos perspective or chaos theory perspective, we never know when these holes are going to line up and which ones are going to line up, because we have different, independent, random systems that are functioning in the same physical space where we have humans taking care of humans. And so these holes may line up, and I also don't care how big the hole is or small the hole is for any particular patient. As an example, you could have a 19-year-old who has a motor vehicle accident, a proximal femur fracture, and post-operatively his blood pressure's in the 90s and his pulse is in the 120s, and he's in a lot of pain, and we accidentally give him an extra dose of opioid. He might hiccup, He might snore once, but probably nothing's going to happen. Now have that exact same scenario in a 92-year-old female who has fallen and has a proximal femur fracture, and her blood pressure is in the 90s and her pulse is in the 120s, and give her an extra dose of opioid, and it could kill her. Exact same systems, exact same vital signs, exact same error, completely different outcomes. So one of the things that we've learned and we've studied in our reliability work and in my personal thesis work is a lot of how we scale and give grades to severity of impact has more to do with the patient's physiological reserve than it does with the error itself. It's not surprising that we find more of our errors and more of our things in healthcare in the infants and the elderly, but not as much in the youth. Does it mean that they're not happening to people in their 20s? Of course it's happening to people in their 20s. They're just strong enough from a physiological reserve perspective to not make it obvious to us, not have an extra day length of stay, not have any rash or anything that comes out, versus the people on the vulnerable ends are the ones who are showing us where our system vulnerabilities are. So that's why we teach people that we're splitters, not lumpers, and we want to identify absolutely everything that patient experienced that we wouldn't have wanted our own loved ones to experience. So I mentioned an 80-20 for standardization of implementation and then modification or allowance for modification as we do implementation. And this comes to our non-negotiables. So all of the sites that are participating, and these are from Mayo. This is the same non-negotiable list we used at Mayo. I'm not going to go through all of them. It could take me 2 hours just to do this, but I'm just going to run through them. System review, not peer review, already discussed. Deference to expertise, reliability engineering principle. Every case is reviewed by nurses and doctors who are still in the trenches to the best of the ability of a particular hospital. Because more than 80% of what we're identifying that we can do something about are omissions, not commissions. So what are we asking reviewers to do? We're asking reviewers to find what's missing. And how can you find what's missing if you don't know what's supposed to be there? I can't keep up with hospital medicine, let alone cardiology, pulmonology, critical care, emergency medicine, and all the different surgical specialties. So I need to review cases that I'm familiar with or at least have a good handle on so that I can recognize that new guideline that came out of the American Heart Association that went into effect last week, the New England Journal publication, I need to be able to know that came out so I can identify the absence of the appropriate care based on what that latest new guideline is. And people who aren't in the trenches just can't keep up with everything. We avoid oversimplification, and this is in reference to the screening process that takes place when some sites do their mortality reviews or their other case reviews, and how we choose which cases are, quote, worthy of a doctor's time. I believe all cases are worthy of my time because all cases have something to teach me either clinically or from an emotional intelligence perspective. And so I bristle at the concept of, oh, they were too old, we don't need to review them, or oh, they had cancer, or oh, they were going to die anyway, or oh, they were very complex, or oh, they were non-compliant, or oh, they were homeless. I detest how we dismiss patients and their experiences when there's probably something in there. It could be hypotension on the floor, medical floor for 8 hours, or high respiratory rate, or uncontrolled pain, that even though those patients were old, had cancer, and were going to die anyway, maybe they didn't need to have that experience in our facilities. So I don't want to oversimplify things by excluding patients the way we have historically in healthcare. We use our multidisciplinary, multi-specialty sessions to build consensus. This is the magic sauce, has been the magic sauce in every hospital that has participated. And I've got two stories that I'm going to share with you very briefly. One was at one of our university settings where a neurosurgeon was participating, and I wasn't at this meeting. They were several months into their implementation and having their monthly meetings where people come forward and discuss the cases. And a neurosurgeon who had done the review didn't find any opportunities for improvement in the neurosurgical case that he was looking at. But the nurse who did the review, who happened to be a fairly junior nurse, found several opportunities. So they each present in public. You can imagine with the existing hierarchy in many of our academic centers that nurse was a little rattled when the doctor said there were no opportunities, but she spoke up and said that there were. They debated. Somebody pulled the mom card, and I'll explain the mom card as it's become known to you in just a moment. And they came to consensus that what the nurse found were opportunities for improvement, even though the surgeon originally disagreed. He ended up coming around to the same viewpoint that she had. After the meeting, he went and, quote, hunted her down in the hospital. This is what I was told. He found her on the floor where she was taking care of patients and shook her hand, introduced himself because they had never met before, and thanked her for speaking up and for identifying things that he didn't see. The culture in that organization between those two individuals that was visualized by everyone standing around them changed on a dime because two people spoke to each other and shared a patient experience amongst other colleagues. Another nurse in another hospital came up to the individual who was running this, another nurse who's helping to run this program at their hospital, and asked if they could join the Magic Club. And the nurse said, "The Magic Club?" She said, "Yeah, that place where all of you and your colleagues, the nurses and doctors, all get together and talk about cases together. I've heard it's like magic. Can I join the Magic Club?" And so what we've seen is a volunteerism return in these sites that we haven't seen before, and watching people's eyes light up, because this is hard work. I mean, a review takes an hour. But watching their eyes light up when they talk to each other about these cases and begin to see changes happen within their organizations is some pretty special stuff. Everybody's recording things centrally in the software, so we have a shared registry, so we have a shared nomenclature and workflow. It's allowing sites to right-size their quality improvement initiatives as quality improvement resources become more and more scarce. We can't afford to do large projects, especially if the project only required a little bit of resource in one place, yet we tried to implement it across the whole hospital. This allows us to figure out exactly where the problems are, because with this work, by doing consecutive patients, you get a much better feel for prevalence within your organization rather than one-off self-reports. The localized implementation, everybody's doing this work a little bit differently, and that's the 20% flexibility that I mentioned. People follow the top 6 principles, and then however they need to get the work done at their hospital is how they get their work done. The language has continued to be really important. This has continued from site to site is another one of the things that we discuss. I don't care if the death was preventable. I don't care if it was an anticipated death. It doesn't matter if what we're talking about caused the death, and we're not talking about just the traditional sense of adverse events. We talk about issues and turn issues into opportunities for improvement, and the change in language has allowed sites to be much more open. We implement Chatham House rules, which means that not only is the patient name not shared or the provider's name's not shared, we also never share outside of the room who said what in the course of that monthly discussion. So this is a very safe place to have difficult conversations about patients who didn't have great experiences and providers who suffered as a result. This is the workflow. This was a graph that was put together, I think, in 2007 at Mayo. It hasn't changed at all, and it's how it's implemented. The top 3 bars are the work that happened between the reviewers and the group of reviewers who would get together every month to turn issues into opportunities for improvement. That's OFI. And then the leadership of it works from there, completing a closing the loop process and generating reports to lift the boat, so to speak, to raise the boat for all, so that all of us gain the clinical knowledge that these reviewers gain by going through these charts, and that we can impact change. This is the mom card, and this was courtesy of a nurse at Mayo Clinic in Rochester in roughly 2009-ish, 2010. We had in 2 consecutive months similar debates and this nurse got tired of our debates. So if you can picture a bunch of arrogant academicians sitting around a room talking about that it was okay for a patient to have a blood pressure in the 80s and 70s on a floor for 6 to 8 to 10 consecutive hours because the ICU was full of sicker patients, or it was okay because they were going to die anyway, or it was okay because they were DNR. And then the next month it happened to be tachypnea, a rapid respiratory rate in the 40s for 8 hours. And it was okay because they were going to die anyway or because they had cancer. We were arguing away how these cases, how these experiences that made us uncomfortable when we looked at them, how it was okay that it happened. We were accepting, we were normalizing deviance, whether the ICU is always full or the ER is always on divert or whatever it happened to be. And one of the nurses got tired of it, and she raised her hand, and she looked at the individual in the room who was arguing most for the fact that these cases were all right, and looked him in the eye and said, could you sit there for those 8 hours while your mom breathed in the 40s and hang on to her hand and just watch? Not get up, not be a doctor, just be the dutiful son sitting at mom's bedside. Could you do it? Well, as you can imagine, the righteous indignation in the room just sort of dissipated like the air coming out of a balloon. And not a single one of us who was making a case that it was okay for somebody else's loved one could admit it was okay for our loved one. And so that became the bar. The bar is not standard of care met. We go into these monthly meetings and in these reviews with two assumptions. Standard of care is met as according to how we would talk about peer review things. And everyone came to work to do their best that day. Everyone worked their tails off. So if everyone's doing their best clinical work and everyone's working as hard as possible, how did this case go sideways? What got in the way of those nurses and doctors and pharmacists and housekeeping? What got in their way to do their best job that day? Those are the things we have to fix, and those are the things that we have to name. High-level summary, this is as of the end of 2018. So we've got another 100, we've got 100 hospitals that have been doing a bunch of reviews since then. But you can see this, about 60% of patients have opportunities for improvement. In those 4,400 patients, roughly, we've had almost 8,000 opportunities for improvement in the 2,600 of them that actually had OFIs. And the average number of OFIs per patient with opportunities is 2.9. This is the Pareto diagram of those nearly 8,000 opportunities for improvement. You can see Pareto diagram being the 80-20 rule. So as an engineer, we would work on the 80% and forget the 20%. So healthcare makes no sense to me as an engineer because our top 80% are the top 6 things on this diagram. So we would work on projects that had to do with end-of-life, documentation, treatment, delayed or misdiagnosis, communication, and recognition of deteriorating patients. We would not be working on medication events, hospital-acquired infections, falls, decubitus ulcers, or aspiration pneumonitis because we've pretty much solved those. They're still happening, but they're super rare. What about the thousands of patients that are having these other experiences? How do we begin to shift some of the resource to fix some of those other things? And those are the things that are facing us now. Now, these projects, if you look at these high-level categories, you can't tell somebody to go out and solve end-of-life opportunities or go fix all the documentation issues. Those are just too big, too nebulous, and nobody could solve them. So as we do the reviews, the reviewers, and we come to consensus about things, the reviewers dive down. Hang on, I'm having a problem here. There we go, into another category. So this is all the hospitals together. But if it was one hospital and if I were queen, I'm not and it's not, but let's just pretend for a second, I would try to get the palliative care team to the patient sooner. Well, you all know there aren't enough palliative care providers to get them to all patients. So which patients? Well, if you dove into this Pareto diagram like we do at each of our sites, you would know it's medical ICUs where there are still non-intensivists, so open medical ICUs, not surgical ICUs, not neuro ICUs, not emergency departments, medical ICUs. So now, it's Queen for a day. I've got a medical ICU. I know who my stakeholder group is. It's the hospitalist intensivist in that medical ICU. And there are at least 4 or 5 really cool projects going on right now within the collaborative around trigger tools to identify patients who would benefit the most, or time-based triggers to identify patients who are having a longer than expected length of stay in the ICU, who automatically get palliative care consultations for a goal of care conversation. Now, can intensivists do goals of care conversations? Of course they can. But do they have an hour to sit at the bedside of an intubated patient and write out on a whiteboard what's going on? Nope. But our palliative care team does, or people who are trained to do that, our social workers or chaplains do. So people are getting really creative about how to do that, and they're targeting the portion that will give them the biggest impact for change. This is an example of an omission, not getting a palliative care team. And we've all heard the stories about getting palliative care involved, how it decreases length of stay, decreases resource utilization, et cetera, et cetera. And that in and of itself begins to fund the work that needs to continue to be done as we work down this spectrum of the things for the end-of-life opportunities. Under each of these is also a layer of human factors. So we have translated the DoD's Aeronautical Engineering Human Factors Classification System into English and clinical language so that the reviewers and the committee members, as they're talking about the cases, can attribute things to individual provider factors. So maybe it's a nurse with less than 1 year of experience, or it's an intern who didn't know when to get the cardiology consult, et cetera. Or general or observation factors. We were charting vital signs every 12 hours, but the patient was sick enough for every 2 hours. Or diagnostic-related things. The test wasn't available at that hospital. The patient should have transferred to another hospital. Or communication and teamwork things at handoffs. Or organizational-related things, such as people are still allowed to do double shifts, or not enough staffing on the floor, or the ICU is always full, there aren't enough beds, or some other administrative sort of action. So that's where we get into some of those things, because until we understand the initial aspects of what's going on at the detailed level, then we're not going to be able to truly fix the processes and systems that are getting in the way of our providers doing their best jobs. Without getting to the bottom and understanding the details of what's actually broken, our quality improvement projects are going to continue to look like this picture. How many of you have been involved in quality improvement projects that when you finished the project, the bridge wasn't where you thought the bridge was going to be? Or what you needed was a pedestrian bridge and you put up a 6-lane bridge, or vice versa? Or the bridge didn't even make it all the way across the river? Until we get into the detailed patient and provider experiences to get accurate engineering design parameters, we're not going to get it quite right. So heart failure is a syndrome, right? We take time to figure out why the patient had an acute heart failure. Was it ischemia? Was it salt ingestion? Was it diet compliance? Was it they didn't take their diuretic because they were going to be in a car? What was the reason why, so we can fix it? Yet readmission is a syndrome. It has multiple causes. Why don't we do the diagnostics so that we can find the engineering design parameters to create the appropriate quality improvement initiative that's going to get us the bridge? The bridge still won't line up, but we ought to be able to get a lot closer than we are now. We ought to be able to make a measurable impact from the word go if we've taken the time to design and diagnose the symptoms and the syndromes that we are seeing in our healthcare processes and systems. Now, I wanted to show you one other really brief cohort, total knee arthroplasty cohort, because I wanted to show you that it's not just mortalities that we're working from. So we looked at a group of total knees from a number of different hospitals, and we wanted to find a cohort that had high opportunity in the value-based purchasing world to be those sorts of patients that would fall out of bundle. And this came to us because of a few hospitals that had been penalized for poor performance in their orthopedic patients. So we started with total knees. So patients that would automatically fall out of bundle, we took those that had an excessive length of stay, so more than 4 days length of stay, or a readmission, or a death in the hospital. And we looked at those cases. Average age was 80, length of stay almost 7 days. You can see which ones made it in for readmissions or mortalities, and 91% of these patients had opportunities for improvement. Now remember, from the mortality cohort, it was 60%. It was 91%, and the average number of opportunities for improvement was 4. Now, the Pareto here looks different than the other Pareto. Now, it's not surprising that when you look at deaths, you have a whole bunch of end-of-life opportunities, but only 5% of the patients in this cohort died. So end-of-life opportunities is group number 5. It still makes the top 80%, but it's not the biggest piece. We have documentation, delayed or misdiagnosis, treatment opportunities, and transitions that were a bigger issue. So depending on what cohort you review, you end up with different types of categories of opportunities for improvement. And here's just a few case examples so that you could get a feel for it. So some of it under documentation was coding. This particular institution was only getting credit for severity of illness and for expected mortality based on having the only diagnosis be osteoarthritis. Well, that patient shouldn't die, but the patient also had chronic renal failure, heart failure, and type 2 diabetes. That's a very different expected mortality rate. It's also a very different reimbursement when you have HCCs that are included. So that's a huge issue for some of these hospitals. Delayed diagnosis, usually it was pulmonary. So we had a patient who was 4.5 liters positive in fluid, and on daily notes from physical therapy, the patient couldn't participate because of dyspnea. They were sent out on day 3 because that was the protocol for this particular hospital, and they were readmitted in less than 24 hours with acute on chronic heart failure because they were volume overloaded during the hospitalization. Cost them 5 days in the hospital. 62-year-old unrecognized central sleep apnea. Couldn't participate in therapy for 4 days. Treatment delay. We had somebody with unrecognized alcohol withdrawal. They didn't get the appropriate treatment. Cost them 2 days in the hospital. 52-year-old who needed skilled nursing facility. They were very obese. It was very obvious they were going to need it if someone had taken the time to think about it in advance. It was not anticipated. They did their surgery on Thursday, ready to leave on Saturday, but the nursing homes in that area didn't take patients on weekends. Social worker didn't learn about it until Monday. Patient didn't leave until Tuesday. Cost them 3 days in the hospital. So those are the sorts of things that we're learning, and you can see how these things would really help patients and providers and systems struggling with the value-based purchasing work to identify where they can improve their processes and systems of care. Now, there's a new society, a Society of Improved Diagnosis in Medicine, SIDM, that's come together, and it's a really big deal. It was the latest National Academy of Medicine report. And so we're studying separately and with them the concept of delayed or misdiagnoses. And we're getting past what they are into why they are and trying to diagnose a syndrome of delayed or misdiagnosis. So if we look at things, it could be multiple different things. Are we delaying or missing the diagnosis because we got the wrong diagnosis? I think that's where people's brains usually go. The doctor made the wrong diagnosis. Well, it could be sepsis or heart failure or exsanguination, this type of shock. So it could be the wrong diagnosis. It also could be you got the right diagnosis but didn't understand the severity of illness and as a result didn't treat appropriately. So you've got the right diagnosis, kind of, sort of. It could be a process or system breakdown. You may not have the diagnostic expertise, the right specialist, the right test at a particular facility, and as a result have to transfer or don't realize that you have to transfer and as a result miss something. Or it could be attention to detail. I don't know, those of you on your EHRs, if you have Epic, if you've ever clicked the hide copied text box when you're looking at a note, and all the text goes away except for a bold word "and," meaning the exact same note was copied from the day prior. We kind of lose our ability to see the detail of day-to-day evolution of a natural history of disease if we're copying the same note from day to day to day. So Some of it may be attention to detail. So beginning to understand and break these things apart is going to be really important if we're going to begin to get a dent into diagnosis and diagnostic opportunities in medicine. When we first started the collaborative, we recognized at Mayo that we were able to describe what was under the surface of the water, what was lurking under the surface for that iceberg, or define what that iceberg was. And our hypothesis as we took this out to other sites was that, or I guess our null hypothesis was Mayo Clinic's the only one that has this experience, and to test whether or not that null hypothesis was correct. Well, I can tell you at every site that's doing this work, 95 to 100% of what they're finding using SLS is not in their voluntary reporting, root cause analysis, or surveillance systems that they have in place. So we are seeing that pattern at other facilities. And I want to just show you, we call it our Iceberg Analysis. So on the left is Mayo Clinic's. We've been doing this for over a decade. Every 2 years we put together a new iceberg so we can see what we're learning with our mortality review or safety learning and what's being found in other places. So I want to walk through this iceberg. So at the top, tip of the iceberg, visible to all leadership, regular reports coming out of, we had 57 patients who had hospital-acquired infections that were identified with our surveillance, electronic surveillance mechanism that were not found any other way in our organizational learning process. AE with harm, those are the voluntary reports with harm, 37. Then 133 patients, unique patients, who had opportunities identified that were unknown or not at the tip of the iceberg. They were the stuff underneath the surface of the water. On the right, you see a healthcare system that we've been working with, and they had, of their initial 92, 70 unique patients that they found opportunities for improvement in. 17 overlapped with their patient safety reports, 4 overlapped with their hospital-acquired infections. But when you break them out, you end up with, now those were patients, unique patients. These are the actual events. Did we have the same events found in both places? And in this scenario, 24 patient safety reports were not found in SLS. 3 hospital-acquired infections were not found in SLS. There was very little overlap, but 193 unique opportunities were found in SLS that were not found anywhere else. They were completely unknown to that hospital leadership, not showing up on any reports, and they were all omissions of care. So those things, those opportunities are blind spots for our existing organizational leadership. And as a result, just like that compare and contrast diagram I showed you where the two were different, and I said they're better together, because we're doing all three, they have a much better understanding of what's happening with the organization and a much richer understanding of what needs to be fixed. Throw readmissions in there, we'll learn some different things. Throw some opioid related issues in there, we'll see some different things, and we'll begin to fill out the whole iceberg. I want to pause for just a second and express gratitude to each of the sites that is doing this work, because they are honoring the lives of the patients who have died or been readmitted or had longer than expected length of stays within their facilities. They're doing what any family member coming in and wanting to know what happened, they're doing the one thing we all ask. Can you make sure this doesn't happen to anybody else? Or what are you doing to ensure that this doesn't happen to anybody else? And they can look them in the eye and say, we're honoring their lives by studying their experience and building up the cohorts or the clusters that had a shared experience so we can understand what we need to fix. They're reflecting on the good stuff that they do. They're accepting the failures that they have. They're recognizing the clusters that are falling through the cracks. And they're getting really creative and remaining compassionate as though those patients were their loved ones, and coming to consensus about the issues that they identify as individuals using a Delphi approach, and coming to consensus about which issues are opportunities. And they're keeping it elevated above keeping it too simple. They're honoring their own family members, and they're evaluating these cases as though they were their own family members, and keeping it out of the muck of blame of the individuals who provided the care. We have a huge patient advisory component. A number of our sites that are involved are actually paid for by benefactors in their hospitals. We have a patient advocate who lost one of her twins in a unfortunate delivery situation, and she's an advisor and actually helping hospitals within the collaborative frame up how to have the conversations as they study these cases, how to take these cases back to the family members. She's helping them with that. Her background is in organizational psychology, so she's well fit to do that. And we have one of our sites that's adopted another facility and helping to pay for their membership. And so we're growing that collaborative and advisory component in multiple unique and creative ways. Each one of the hospitals that's participated has had to recognize that reviewing these lives and reviewing these cases doesn't solve the problem. But identifying clusters of shared experiences, identifying those common patterns that those shared experiences have, and targeting those things as design parameters and quality improvement initiatives, only then will we see the changes in our processes and systems as we shore up the last few cracks that we have that our patients are falling through and our providers are experiencing. Then we're going to make the measurable difference we all hope to make. Without action, I shared a couple of experiences about how we're getting nursing and physician engagement, people who want to join the Magic Club, how that's changing the culture on the floor, even without leadership intervention. But when our leaders do intervene and we hand them in a well-packaged bundle what's broken, where it's broken, who the stakeholders are, what types of patients is broken in, and how that would scale, what that would look like if we gave a prorated number for the year for that facility, now we can start talking about cost avoidance, improved efficiency, efficacy, improved diagnosis, et cetera, and make a difference in the lives of our patients and our providers. As a result of all the work, there's a whole curriculum that's been developed that entails all of these different parts that we've been implementing and putting out, but with videos and a lot of on-site training, which has just been incredible. We've got other people participating from other organizations who have done the reviews, done the training, who are helping to do the training now. And we're seeing a train-the-trainer model grow and within the organizations that are participating. These are all the different types of cohorts that people are studying, and the list is absolutely endless in terms of what we're able to do. And if you don't want to hear from me, but want to hear from some of the collaborators themselves, this is a YouTube channel out there that you can go out to and hear their perceptions of what they think. We get together annually in Orlando in conjunction with the IHI meeting during non-IHI meeting times, and get together and work together and learn together and break bread together. And it's just an amazing experience for any of you who would like to join us. And with that, I'm going to stop the formal aspect of my presentation and open it back up to you, Dr. Denham.
Thank you so much, Jeanne. Fantastic. Really, really terrific presentation, and so many wonderful areas to dig into. We're just, because we survey our audience, Jeanne, every time, I want to make sure that that we have the survey start. Kyle, would you please start our survey? And we will ask again, do you want more on the mortality review information, another webinar? And Jeanne, this might be where we invite, as you know, we like to invite folks that are involved in your collaborative to share their specific drill down experiences. And so we're just fishing to find out, would people like more on mortality review? This has been a great teaser of your great progress. Do people want to have more? So give it a strong 10 if that's really what you'd like, and you'd like to have more that would complement what Jeanne delivered today. And then the free text entry question that would follow would be, what would you like to have covered, so that you could address those areas as well. And then the second question is regarding next month we have the former Chair of Quality or Chief Medical Officer for the Cleveland Clinic, Dr. Henderson, who works with WHO and has been a close collaborator of ours, is now the Chief Medical Officer at the University of Mississippi, and his CEO, who actually was one of our former teammates, are going to talk about their leadership journey in terms of bringing quality and climbing the quality mountain. And like to know, are there topics that you'd like to address regarding CEOs, working with your CEOs, and the partnership between the CEO and the Chief Quality Officers? And then in August, a very hot topic and very important is workplace violence and how to deal with that. It's definitely on the rise, both from within our own care leader, or our own care providers, between providers and administrators, and also the workplace violence in the environment where patients and families are interacting with our leaders. And we also will address this growing and exploding problem of caregiver suicide, which we'll cover. So now, in terms of reaction, I'd like to have anyone who would like to ask questions of Jeanne to enter. If you go to the right side of the panel on the WebEx, you can click on Q&A and address the questions that you'd like to ask of Jeanne. And I've been receiving some here for you, Jeanne. I know that the first question is this area of diagnosis, misdiagnosis. We understand that there are some major publications that will be coming out in July, and one of our former teammates who we've worked with closely, I talked to Sue Sheridan, who's now with that organization, formerly with Precori, said that there should be some announcements going on. Can you give us any idea of what we might see in the next couple months on misdiagnosis?
I am unaware of the specific science that they're doing in that particular, in those. They haven't shared them outside of their writing group, to my knowledge. I do know that we're sharing a venue in their fall CITM meeting in Washington, D.C. We're sharing presentations, both what they're doing from CITM and our collaborative work. But no, I don't know what's going to be in those publications. I'm anxious to see them as well.
Great. So we're waiting. We hope by the time we have our next webinar that there'll be publicity releases and announcements, and I think all of us are just waiting to hear. We've been waiting, knowing that in some of our, and I won't say what, but in some of our leading journals, that there'll be some really important information regarding this topic, and so we'll be watching for that in the next 30 to 60 days. Next question, Jeanne, is for organizations that are just now starting to learn about mortality reviews, can you give us a step-by-step strategy for a non-academic center to be able to introduce the idea, and then how much, how soon, how often? How much does it cost to join the collaborative? And how would a group, kind of a step, can you just walk us through the steps of how an organization could, A, get it introduced, and then ultimately, if the end goal was to join your collaborative, what would be the proper steps now that you've been doing it for years?
Just to reach out to me as an individual. So anybody that's interested reaches out to me, and then I provide presentation materials and information by email that can be shared within the organization, and usually hold a meeting with the quality team and any leadership so that we can discuss what the collaborative is doing and where we're headed and how we might be able to help their facility. The cost is variable depending on the size of the hospital. We've had some very small hospitals, public hospitals, VAs, et cetera, that pay one rate because we're a social benefit corporation, because I take no remuneration whatsoever. As a social benefit for county hospitals and VAs and others, we have, and in critical access hospitals, we have a lower rate than for those that are bigger. Our highest rate is $25,000 a year, and that includes the software, all of the materials for training, et cetera. And then there's a little bit extra for on-site training from me.
Great.
To cover travel.
Yeah, fantastic. And I'm going to drill down on that question just a little bit deeper. We know that, our administrative leaders are always saying, well, the price is one thing, but the staff time that has to be dedicated to it. So, for, let's say, a 300-bed hospital, there's so many of those in the United States and abroad. 300-bed hospital joins, how much staff time would have to be compensated staff time to be involved, just so that you could look at a total cost of participation? Because I think it's very low. It's surprisingly low, but just to give people kind of a ballpark of how much time and who would have to be involved.
It completely depends, because of the localized implementation being one of our highest values. It completely depends which implementation route they take. So we have two hospitals now that culturally weren't ready for a full-blown implementation of organizational learning and change. So we did the first 100 reviews for them. So they paid us to do the reviews. So we go on site, we spend a week, 2 doctors, 2 nurses that are all collaborative members, and we do the reviews. Did I send that backwards accidentally?
No, I did, because I want to come back to the next question, because we've got a couple of questions on the topic. So that's one route, and there's no cost for on-site other than an administrative assistant to help me figure out what hotel to go to, I guess, or what room to report to. And then another step is just to do the first 100 cases, and so that has the only that's needed, that's usually paid, as a project manager to help organize that, and then the physician and nurses are volunteers for those first 100 cases. I mean, our first 100 cases, we had 3 docs and 1 nurse. We each reviewed 25 cases in 3 months. So it doesn't have to be a big thing. Then for those organizations that are doing a full-blown organizational implementation across multiple hospitals, have a project manager, a physician and nurse lead at each hospital, and then a physician nurse lead at the system level to shepherd the whole process of onboarding everybody, selecting cases, getting them entered, all of those sorts of things. And how much time would they have to spend on a full-blown multi-site, those individuals at those sites, so the doctor and those folks that you just mentioned?
Less than 10% of their time.
Great. Yeah, that's what I thought. Because, the work is so compelling that sometimes compelling seems like it's going to be expensive in terms of the soft light green dollars of capacity and the dark green dollars. And I just think this is rounding error compared to what it costs to just take care of someone when you do, have miss an OFI, if you will, and that kind of thing. And that kind of leads to one of the questions that I fielded here is, if you look at have folks been able to go back to leaders and say, boy, we joined this, and the ROI, the return on our investment in terms of saving dollars has been X. So if you kind of look at the icebergs here, where has been the low-hanging fruit to make the most CFO, the most financially focused CFO feel relieved?
End of life, getting the palliative care team to people, getting them into hospice sooner, which impacts both the expected mortality and their O to E for mortality, because they don't count as a hospital death then. That's been a big one. Delayed treatment has been another one where they've identified that more than an hour delay in treatment of sepsis, that's 8% mortality or 3% mortality, increased mortality per hour. So you decrease time to treatment by an hour. Doesn't take very long to do that calculation. And then the other one is recognition of deteriorating patients and getting patients in the right space. Triage is a piece of that. Getting patients in the right space to get the most intensive treatment they need for the most rapid recovery and decreasing length of stay. So those
I'm going to ask you one question, and then we have another question regarding your contact information, and I'll have you recite that. But we've really had an eye opener regarding the pre-hospital care continuity, from a victim having a major traumatic event, sudden cardiac arrest, anaphylaxis, any of the issues that we covered earlier, handoff from the bystanders, where we found that if you can get to somebody within 3 minutes, your survival might be 70%, whereas if you wait for EMS, it's 10%. But if you kind of look at the pre-hospital care handoff to the ED or handoff to the hospital, where were the OFIs there in terms of So these are emergency admissions to hospital. What are the areas for improvement there in terms of all comers coming through the door by ambulance or families being brought with acute issues?
Some of the things that we've seen and that we want, sepsis recognition in the community, so people waiting too long to come in with sepsis. We've done a great public health job on strokes and MIs. Sepsis needs to be that next public health education piece that goes out so people come in sooner. The other is...
Can I interrupt you there and just ask you? We know, working with the cancer, and as a former cancer doctor, we know that that people waiting to chemo patients or patients that are receiving treatment for cancer wait too long, watching their temp, watching how they're feeling and that kind of thing. So people that have chronic illnesses, as well as is sepsis also in the general population? So in the general population as well?
Nursing homes. Yep, and nursing homes.
Okay. Good. That's really helpful.
Huge. The other is making sure that all of the ambulances have access to, so two things we've seen. They don't have an ECG machine.
They don't have what?
An ECG machine.
Okay.
Ambulances that can't run an ECG, and then ambulances that cannot trigger the cath lab.
Okay.
We've seen breakdowns. If the ambulance can't trigger the cath lab in the middle of the night, they require a cardiologist to trigger it. You've just lost 20 minutes if you found a sleeping cardiologist to look at an ECG to trigger the cath lab team. You can lose 20 minutes.
And when you're talking about an ambulance that can transmit the ECG.
Yes. Have one.
So they have to have the equipment, but they've got to be able to transmit it from the site. Yep. Great. Jeanne, and I'm going to come to you, Arlene, with any questions that you might have. Jeanne, can you give us the best contact information?
I've tried to type it in so I can respond to this question, but I don't know, Kyle, if you can make it so that I can.
Kyle, can we put a slide up with Jeanne's, or I can share my desktop if we want.
Kyle, I'm sending you what I was trying to post, so you can copy and paste it onto the screen.
Great. Got it. Great. Next question was regarding the patients that, if you were to talk about the best examples of the most compelling examples that could be shared with boards of directors, what would they be? What are the stories that seem to have the greatest impact on a board of directors that say, listen, this is out of budget, but we're going to write a check?
When we get into the cluster analysis, when I can show them that groups of patients that have similar experiences, whether it's not recognizing obstructive sleep apnea or not recognizing prolonged QT intervals in patients getting antibiotics, or deteriorating patients' recognition of severity of illness, people not recognizing that in the ICU, and I can give them the specific engineering parameters that we find by doing our cluster analysis, and every single one of them are things that every hospital has experienced. If they know anything about the care that's going on in their facility, and I'm assuming they do, then they would recognize that the stories I'm telling them are things that happen in their facility as well, and how we, through this process, can learn how to fix it locally in a way that's meaningful for their providers.
And so
the iceberg diagram is huge.
Yeah, that's one of the reasons I put it up. And Carl, I just saw Jeanne's material come up, but it looked like it was sent privately. Can you just make sure that maybe it says private, but maybe it came in private, and then you're making it public. One of the other questions that's just come in is how have the mortality reviews changed caregiver education? Are there areas where they're wanting to get more continuing medical or nursing or caregiver education now that they've uncovered new opportunities?
Oh, absolutely. One of the programs that we put each of the sites through is called Intentional Knowledge Dissemination, where we go through a formal exercise of figuring out, there's 4 primary reasons to communicate this information, and so under each of them we go through who should receive it, what message are we trying to give, and therefore what venue do we have to communicate it in, or what vehicle do we have to use. And so it's a very intentional thought process. And so it's everything from feeding M&M conferences to CNSs and NESs, educating on the wards about sepsis or whatever, taking the cases from the system and using the floor's cases for that nursing floor. So it's personal. It is, we've sites that are out offering MOCs and CEUs and CMEs for the work itself. A couple of sites have put together just some beautiful programs around that, so all the docs are getting their MOC credits covered. So it's filtering out in many different ways. I can tell you I am a different physician, and hopefully a better one, because of this work. I look at respiratory rate differently. I recognize shock index. I can tell I just am different. I'm more situationally aware because of this work. And I think that anybody practicing in the trenches deserves the right to have that same level of education without having to read 1,000 charts. So getting that to the trenches is really, really important.
Arlene, would you like to ask Dr. Huddleston some questions?
And I think there's, as you pointed out, there's a partnership that we could have between patients and nurses and doctors. As we tragedies by collecting the data and checking out different systems and improving it. But if you collect that data and nothing's done with that data for patient improvement, then it's not working. So now I see that with your work, we're at that point now, something's going to change. We're going to collect this data, and with your dedication, I could see hope that patients' lives will be saved. And you were stressed that the facility can identify all these opportunities for improvement, but unless they follow through and make the necessary changes, nothing's going to happen with that information. So I want to thank you for your dedication, because it seems like a lot of hard work. And collecting this knowledge gives you the knowledge. And I'm glad that you're sharing that with everyone, because that's how you get the word out, how to improve patient care. So thank you.
Well said, Arlene. Any questions anybody wants to ask here in the last few minutes, please put them up on the Q&A section on the right side of the WebEx frame. Jeanne, how have you've now gone global? Are they seeing the same?
Pretty similar. The communication ones are nursing concerns not being heard by physicians, change in patient status not being communicated to the right physician, and a big one is this concept of no quarterback. There's a bunch of providers, but no one's in charge. And so that's been one of the big things that we've seen in terms of reorganizing our physician and consulting teams so that there's a clear, known who's in charge to the patient, as well as to other providers.
Fantastic. And then one, Jessica Glasgow asks, is this presentation available? And yes, it is. It's on our website for download, and you'll be able, in 3 business days, you'll be able to watch it, Jessica, afterwards. Mariel Mullen asks, what is the Delphi approach?
It's Delphi, D-E-L-P-H-I.
Yeah, because I didn't know. Yeah, so it's a methodology that's used.
Yep.
For
it's a modified. It's a well-known methodology initially in sociology to take disparate opinions and bring them together into a single answer.
We used it to develop the Leapfrog survey, actually, a modified Delphi approach. Now, Jeanne, do you have upcoming two quick things. One is, are you going to be presenting at IHI in December on this topic in the formal IHI program? Number one. Number two, do you have publications forthcoming this year that we can watch for?
2 publications forthcoming this year, and we will not be presenting at the major as a formal IHI presentation, but we will be there. A bunch of the collaborative members are getting together, and we're going to have a Magic Club booth at in the vendor area. So
will there be any sort of presentation or program? Our team frequently used to do workshops at the time of IHI because we have so much going with IHI. Is there anything that any of our audience might be able to attend, even though they're not part of your collaborative?
That's on the list of things we're thinking about. So if you think that folks may be interested in that, then yes, we'll be there. So it would be easy for us to do.
Fantastic. Yeah, we found that to be really, really successful to do. Well, right on time, and I don't see any other questions. Well, Jeanne, really bravo. Fantastic work. I'm going to have Arlene close us, but Jeanne, if you can stay on just for a minute afterwards, when we go back in the green room, we'll talk about what we can do better next time and any resources that we might be able to provide. God bless everyone. Thank you so much for attending. And we have Dr. Henderson in July, and we have workplace violence in August. Arlene, would you please give us the voice of the patient? And again, thank you, Arlene, for your steadfast support and being such a great champion.
Well, thank you again, Jeanne, for the presentation. I really, really enjoyed it, and I'm glad that everyone was on the webinar. And like Dr. Denham said, you could look at it again on the website and play it at your leisure. And I hope you would share it with all your colleagues because this is so important. So thank you for your dedication, Jeanne, and thank you, Dr. Denham.
Thank you. Godspeed, everyone.